All right, we'll go ahead and get started. So this is kind of part two of what we did in the spring. The fall, September, end of September is the last time we had the Gaps in Knowledge talk. This is just going to be taking a list of things that the ABA has sent us as a program, saying that our residents don't do quite as well on these topics, and talking through those topics, okay? So I'll make sure that I go around and involve people so that you can all think about these things. So the first one is, what reflexes must be absent to constitute brain death? So we don't cover brain death a ton really in any part of our curriculum. Has anybody diagnosed anybody with brain death in the unit? Okay. So what reflexes do you think are the ones that we need to look for? Gag reflex, good. Corneal reflex, good.
Like cold or hot water in the ear.
Yeah, what's that called?
I'm trying to think of it.
So it's in the ear, so what is the cranial nerve for that? So vestibular, right? And what are you looking at with what's the response we're looking for? So ocular response. So it's oculovestibular reflex. Good. What's the doll's eye reflex?
You are in the Zoom meeting now.
Oculocephalic reflex. Good. There's really only two others that haven't been mentioned so far. What's one of the first things that the neurosurgeons do when they go assess their patients in PACU and ED? Pupil reactivity, right? Now, the last one's kind of one that you'll see me do in the OR when I'm trying to assess a patient on whether they're light or deep under anesthesia, and that's a cough reflex, right? So you do something that's stimulating to the airway. If they cough, then that's obviously something that is showing they have intact cranial nerve reflexes. So in terms of that, one of the things that you can be tested on is just what are the reflexes, but also what are the afferent and efferent limbs of those reflexes. So let's take a look first at the cough reflex. So what's going to be the afferent and efferent limbs of the cough reflex?
All vagus.
It's all vagus. Good. So that one is easy. How about the gag reflex? So glossopharyngeal is the afferent. And what's the efferent? It's vagus, right? So glossopharyngeal is going to be sending the information. The carry out of that reflex is going to be vagus. How about the oculovestibular? That's pretty intuitive which one should be the afferent, right? So that's going to be the vestibular nerve. And then how about the efferent? So close. It's abducens. So this is the key. When you put, how do you do that reflex first? You had, I think, mentioned it.
Yeah, you can put like cold water in the ear.
Yeah, so it's what's called a colorimetric test, right? So it's temperature changed. So you can do a cold water infusion or dropping of fluid into the ear. Which direction do the eyes move? Toward the stimulus, toward the cold. The opposite takes place when you actually have warm fluid. So if it's warm fluid, it goes to the opposite side. That's the difference between the temperature. I have a funny schematic that I'll show here in a second that will hopefully kind of burn that into your mind. Oculocephalic. So it's going to be the same pathway in terms of afferent. You're using your semicircular canals, right? So it's still that part of your eighth cranial nerve going back and then coming efferent-wise, which pathways? So this one's interesting because it's really all of your extraocular muscles. So oculomotor it will test your abducens. So really the idea with the Dahl's test is that you're moving the head in directions, and what happens with the eyes? They stay conjugate and they stay forward, right? So if you move left and right, they'll move opposite to the direction you turn your head. If you are going up, down, they will go down if you move your head up and look up as you look down. So that's a test that you do to assess whether that is intact, right? So that's the reflex. And then how about the corneal reflex? I've seen this on a test before, so I know this is one that they've asked. What happens with the corneal test? How do you do it? Poke him in the eye, right? Let's presume that your patient is awake. How would you do a corneal, and they're coherent? How would you do a corneal reflex?
Suck it.
Adrian, looks like you know.
You just attempt to do it, and if they blink, then you kind of know.
So with what? What's your stimulating? What are you using? Tissue, a Q-tip, or cotton that is kind of put out into a tip, right? So the idea is that you want to try to go right where the cornea and sclera meet. So you have the patient turn away from you, and they're looking away so that you coming to them with something doesn't cause them to blink, right? And you touch their eye at that junction. So what's going to be the afferent limb then? Trigeminal. Good. So trigeminal is going to be, it's the ocular branch of the trigeminal taking that information back. And what's going to be the efferent? What's the response? Facial, right? Blinking. Good. A couple of other things about brain death. So you have to make sure that they don't have any CNS depressants, right? Sedation has to be off. You got to make sure they're not paralyzed. You got to make sure that their normal temperature. You got to make sure that their vital signs are normal. How often or how many neurologic exams have to be done? You said it?
2.
Yes, so 2. And how far apart do those exams have to be?
A day?
So it depends on the state, actually, but they have to be separated by time. They can't just be serial exams. So typically a day is what most people will say, but it can be as few as several hours afterwards. But the idea is that 2 successive exams separated by time with no reflexes, no other things that could show that the brain is working is how you would diagnose it. What about the apnea test? How does that work?
The CO2 rise.
Yeah, so by how much?
I think above 60.
So there's 2 measures for CO2. For the apnea test, you're looking for a CO2 rise above, so a PA CO2 that goes above 60, or you're looking for an increase from whatever their baseline PA CO2 is by 20. So let's say they're at 35, they would go to 55 or greater, right? So those 2 CO2 metrics are how you would determine a positive apnea test. How do you do it from a functional standpoint? Turn off the vent.
Take a blood gas. Well, take a baseline blood gas.
So aside from the blood gases, how would you actually do it?
I mean, you can use end tidal as a surrogate.
Not even worry about CO2.
Any spontaneous effort.
So you're looking for spontaneous effort in what time period? How long do you do this apnea test for?
Like 2 minutes. Say 3.
So it's actually a relatively long time. You can use, this test is a little bit controversial because if people are going to be a donor, then you don't want them to become hypoxic, right? So hypoxia they use in most cases just like we would use in the OR, below 90% is when they would say, okay, we're going to stop this test. But if they're able to hold their SATs they'll go for as long as it takes until those sats come down, and that can be as long as 5 minutes, 8 minutes. It can be a long time depending on the function of their lungs prior to the test and whether or not they were on an FiO2 of 100%, whether they were recruited, all these other factors that play into it. Any questions about brain death testing?
So why does the test include like PaCO2 as a definition, but then functionally you don't measure the CO2 at all?
Well, people end up doing it in tandem, but you don't need both of those to confirm it. So in most hospitals, a negative apnea test without looking at CO2, so just no respiratory effort over a certain period of time, would be a positive test, meaning that they don't have the drive to breathe.
You're just waiting until they get hypoxic.
Say it one more
They are
time.
breathing.
Say it one more time.
If they do a respiratory drive, you're just waiting until you get to 90, sub 90
Yep.
to end your test.
That's right. And if they have any effort in that time, then it's a negative apnea test, and they obviously have some sort of function that's in their respiratory centers. So it could just all be brainstemmed at that point still.
For once I see them trying to breathe.
So again, Dr. Lewitt, just the brain death exam involves looking for all those reflexes as well as the apnea test, like you mentioned, kind of in tandem.
Yeah, that's right.
That's it. Okay.
That's it. You can do other testing that is not required in most states, but some hospitals have policies. This hospital actually, I don't know if it's a policy, but it's pretty standard that people will get EEG or a Doppler of their carotid to show that they don't have blood flow, or sometimes they'll do a CT angio of the head to make sure they have no blood flow. The idea is that you're wanting to prove that the brain is not chemically active and not metabolically active. So this is that funny picture that I mentioned earlier.
That's horrifying.
So the top one is that oculocephalic reflex, right? Turning the head in the direction that the eyes go. The bottom one is that oculovestibular reflex where you're looking at cold versus warm. And then if it's unilateral versus bilateral, right? So if it's unilateral, it's what we talked about. That's the more common version of the test. This bilateral, I think, is probably not something that people will do. It's just kind of funny to see the way that the eyes respond to that, right? Any other questions about that? Okay. What explains the relative resistance of morbidly obese patients to succinylcholine? So that should be, I think, a CA1 level question. Stephen, what would you say? So, tag team Julio, what would you say?
Volume of distribution.
So that could be one of the potential things. I will say that it's not the main reason. It has to do more in line with how succinylcholine is broken down. So what would you say?
I'll say I know in obese patients, like lean body weight goes up, so I mean there's actually an increase in muscle mass with obese patients. I was thinking just simply like more muscle mass to cover with your succinylcholine.
That's not it either, Adrian.
You said increased volume distribution.
Not to increase muscle mass, it's like volume distribution.
Yeah, I thought they have a higher circulation.
So those things are true, but that's not why for this particular response, that's not why it's seen. So any of the more senior folks?
Increased plasma esterase.
Yeah, so that's the answer. So you're going to see this word, this butyryl cholinesterase. That's the same thing with pseudocholinesterase. They have different words that will show up on different tests, but it's all the same thought, same process. So obese patients and those especially morbidly obese have increased activity of this enzyme. They might have the same quantitative number of enzyme per given measured volume of plasma, but the activity of a given enzyme is higher. And they've measured this to be upwards of 50% higher activity. So for, let's say you have somebody that is non-obese, otherwise healthy, you give them a intubating dose of succinylcholine, approximately how much of that is going to be metabolized before that succinylcholine gets to the neuromuscular junction?
Like 50 to 60%.
Oh, it's 30-ish.
Any others? It's actually really high. Upwards of 90 or 95% of the sucks that you give IV never makes it to the neuromuscular junction. So that's why A, it doesn't work for very long, but also B, you need oftentimes a larger dose to actually get the response that you're looking for. So I used to give Howard Miller a hard time over at Denver Health because he loves to give succinylcholine at what dose? Those of you that worked with him. What dose does he like to give? What's that?
80.
80 milligrams? Well,
Everybody.
so he'll give, his argument is that he'll give 0.3 per kilo, which is the ED95, right? But knowing that you're going to have the majority of your agent dissociated, broken down before that can actually work, you're just decreasing the overall number of molecules actually functioning at the neuromuscular junction. So if you really were relying on muscle relaxation for intubation, you're not going to have as good of relaxation in that scenario. So these patients, you have to give bigger doses, knowing that they have higher activity and knowing that you get very little to your neuromuscular junction with the given dose.
Would your myalgias afterwards, if that smaller dose potentially be less?
So it's interesting. There's
higher dose.
The only thing that has been shown to be helpful for myalgias from succinylcholine is a priming dose of non-depolarizing agent. It's the only thing. So smaller doses don't seem to make any difference. Any other questions about this stuff? What other agents that are metabolized by the same pathway do we give in perioperative care that you would also be worried about?
Okay.
Esmolol, good. What's that? Remifentanil, good. Yes, yeah. So cis wouldn't be one of them.
Esther.
So there's a neuromuscular blocking agent that we don't use that you read about. Starts with an M. Mivacurium, right? So that's something that some places have. I've heard some people that have gone out into private practice and some hospitals will have that. So that's another agent that is this esterase pathway. How about your local anesthetics?
Chlorprocaine.
Yeah, so
Any
chlorprocaine would be any of your esterase class local anesthetics are you're gonna have to worry about. So has anybody used remifentanil and presumed that they had a patient that might have some sort of deficiency for pseudocholinesterases? What happened?
A long wake up and we couldn't explain it because the remi had been off forever and
Didn't want to breathe. And,
didn't want to breathe and
So we always freak out about the person that has cholinesterase deficiency for sucks, which is, I think, important to always keep in mind. But we have a whole host of other agents that we give that you also have to be thinking about.
Can you give naloxone in that case?
Sure can.
Would that work? Did you try it? Or did you just sit there?
we just sat there. We just sat there.
We got time. Oh wait,
we
it's
just didn't know
2:45.
that for a
Get out of
week.
the yard.
He's still in the ICU. Yeah.
Which metabolite of hydromorphone will accumulate in renal insufficiency and may cause neuroexcitation and cognitive impairment? Do you know?
Oh man, it's on the tip of my tongue. It's like saying like 3s and 6s.
Yeah, 3s and 6s. Good.
Multiple choice approach. You're like, I would recognize the lineup.
Anybody?
M6G or something like that? That's more.
What can they use?
So you're very close. It's hydromorphone 3-glucuronidine. So this is one of the breakdown products of liver metabolism for Dilaudid, right? So this agent is actually probably making up 1/3 to 1/2 of all the metabolites for Dilaudid. So it actually accumulates in pretty substantial concentrations. Doesn't have analgesic properties at all, is excreted by the kidneys. So this is why if you have somebody that has renal insufficiency or renal failure, if this accumulates, this excitatory response is something that can be seen. So what might that look like? Does anybody know what that looks like? The neuroexcitatory effects of this agent.
Seizure?
So seizure can happen, but that's extremely rare. Mm-hmm. Remember, myoclonus is going to be more of a muscular response.
It's going to look like delirium.
So it can look like delirium. Agitation is pretty common. Hallucinations, pretty common. So that's the kind of excitatory aspect of this agent. So it's often not going to comatose your patient. It's not going to have them go into seizures in most cases, but they might be tripping out, right? And you can't really explain why. So that's an agent that you want to be thinking about when you're using Dilaudid in a patient that has renal dysfunction.
So actually, I think about this. Like, what about like a 2 milligram dose without impact? Is that enough to cause an accumulation in effects?
Probably not. It probably has to be sustained over time. So I think the more clinically valid reason to think about this is your acute pain patient that you're taking care of that's on a PCA on the floor. It's probably the scenario that you worry most about this clinically. Perioperatively, often we're not getting enough total dose that's going to make a huge difference. How about some of the other agents? So codeine shows up on tests quite a bit. How is that metabolized?
SIP system? Yeah.
Yeah, so cytochrome P450 it is going to be the way it's metabolized. What is the active ingredient? Because codeine by itself is not active, right? What's the active? It's morphine, right? So it has to be conjugated into morphine. What happens in these patients because similar to this agent, there's a morphine 3-glucuronidide that is also accumulating in patients that have renal dysfunction. So that's another agent. But that particular metabolite doesn't cause neuroexcitatory responses, at least not to the same degree. It's more likely to cause the more classic things that you think about with opiates, sedation, itching, things of that nature, right? So it still acts on those opiate receptors. What about, let's see, we just talked about morphine. What about hydrocodone? Hydrocodone is, again, Vicodin or Norco. What's the active metabolite there? So I like to think of this in terms of how you would imagine your IV agents, right? So we just said that codeine goes into morphine, right? Hydrocodone goes into hydromorphone, so it goes into Dilaudid, right? So that's going to be your active ingredient there. So same sort of thing with hydrocodone. So that agent, if you have a patient that's taking it on an outpatient basis, they can have this neuroexcitatory response to this molecule because they're not filtering it and clearing it. Meperidine. It shows up on tests all the time too. So its active metabolite is normeperidine. And what's the big side effect if you can't clear that?
It's neuroexcitatory, right?
So seizures. So whenever you see seizures and opiates, you always want to be thinking about meperidine. Kind of an interesting fact, fentanyl, sufentanil, methadone, things that we use more often in the OR environment, are metabolized and they don't have active metabolites. So that's different than a lot of the other agents in this class. What are the cardiac effects during an ECT? Has anybody done an ECT? All right, so what'd you see?
I don't know, I wasn't really watching the EKG. Honestly.
What were you watching?
I don't know, the dude like threw his arms up and then he would put him down and Khalil over at the VA was like, I've never seen that.
So maybe the one you saw wasn't a good representation. Did you raise your hand, Nick?
Yeah, see bradycardia.
Yeah, it's like profound bradycardia.
So you can get profound bradycardia. That's what we worry about. But what's the most common response that we actually see, though?
Hypertension and tachycardia.
That's exactly right. So you're exactly right that bradycardia is what we worry about. By far and away, what we see most often is that heart rate will go up and BP will go up, right? So you have this massive neuro output from the seizures. What happens, did anybody, either of the cases that you guys did they have cardiac disease? So what's the risk of doing, you said yes?
Yeah.
So what cardiac disease did you have?
We had some probably undiagnosed COD, so that's the elevation or depressions.
Yeah. So does that worry you then, doing ECT in a patient that has cardiac history? So what's worrisome then?
Well, it's basically a positive test. They're stressing out their body.
Yeah. So that's a great way to think of it. This is a stress test for the heart. So if you have somebody that has cardiac disease, what you're looking for then are going to be arrhythmias that take place, and obviously ischemia that takes place. Good. During one lung ventilation, what drug classes can attenuate HPV? So I'll save this for a CA3. What is HPV, Shelby? Describe it to me. What does it do?
Essentially, your lungs will respond to hypercarbia by limiting blood flow to areas that are not being oxygenated very
So
well.
is it hypercarbia that it's responding to?
Hypoxia
Hypoxia.
in the name. Yeah, that is correct.
So the idea is that, and the mechanism's poorly understood, but the thought is that it's in the pulmonary vasculature, the pulmonary artery vasculature, that there are sensors for oxygen tension, and that when you have low oxygen tension, and the oxygen tension is not within the vessel. Where is that oxygen tension being measured from? The alveoli. So this is a way that the body is saying this particular alveolus over here has low oxygen tension. I'm not going to send blood over there because I'm not going to get oxygen, right? And so it's the body's way of shunting blood to areas with good ventilation and good oxygen concentrations. So the reason why this becomes important is because we see this in one lung ventilation, so that's why it's up here. So what happens then in a patient with one lung ventilation, Nick?
Well, one lung is basically hypoxic, so you get a lot of vasoconstriction to that lung that you're not ventilating. So you're hopefully shunting blood towards the oxygen or the ventilator lung.
Yeah, so that's the hope. What actually happens in practice?
I mean, you still get some blood flow to that lung. It's not 100% like that.
Yeah. So, Kenny, what happens when your patient starts to get hypoxic? And you've already employed adding some P, maxing out your FiO2. What things can you do to try to remedy that?
You can add CPAP to the down lung if possible.
Mm-hmm.
If you're not going to.
Let's say that Mitchell's complaining. It's too much.
Yeah.
Can't see.
You can potentially try reducing PEEP. Sometimes that helps by increasing perfusion to the lung that's being ventilated.
Yeah.
Or you can change your IDE ratio to have a longer inspiratory time.
So let's presume you've done all those things and your patient still cannot tolerate one lung ventilation. What is it that you can tell the surgeon to do? Clamp the PA, right? A mechanical shunt. You prevent blood from going to that non-ventilated lung. So in most cases, HPV is going to help you so that you don't have to go that far, right? You get enough of a response so that it shunts blood on its own to the side that's being ventilated. But sometimes you don't get that response, or it's not as robust for a variety of reasons. And we'll talk about some of those reasons in a second. So what drug classes attenuate this response? You've done CT, right, Haley?
I don't know. Yes. I'm trying to think. This is really embarrassing.
It's okay.
For attenuate, am I saying makes it worse or makes it better?
Makes it worse, right? So they're not responsive. That response is not doing what it's supposed to do.
So if you think about alpha blockers, well, at least you're not going to get vasoconstriction from that.
Mm-hmm. What do you think, Jane?
So let me make sure, I'm with Haley, I'm making sure. So you're saying that the response is not happening as much as it should.
Correct.
So anything that would cause pulmonary vasodilation, like milrinone,
Yeah.
ibuprofen, or anything like that,
So that's exactly right. So there's a whole host of things. Why isn't this thing not moving? There we go. A whole host of agents that will make this response not work. So on tests, oftentimes you have patients that will be on an outpatient regimen. Calcium channel blockers, ACE inhibitors will be the most common things you'll see on those, where those patients are predisposed at baseline. If they have a surgery where they're on one lung ventilation, they may not have a robust response for this HPV. Okay. Intra-op, of course, our volatile agents attenuate this. And I'll show a pretty neat graph here in a second that shows to what effect that takes place. So sometimes in these patients, if you're really worried about this not working, not helping you out, and the surgeon says, I can't clamp the PA for whatever reason on that side, that's a particular situation where maybe an IV anesthetic is a better anesthetic to try to preserve as much function of HPV as possible.
Volatile, you said make it worse.
That's what you're saying.
So
Yeah, because you want, so in one lung ventilation, HPV is good, right? So you want HPV to be robust in one lung ventilation. Correct. Other things that affect HPV that are not drug class mediated, CO2, I think was mentioned earlier as being something that can impact it. So this is when you see pulmonary hypertension patients come through, we always worry about their CO2. So that can actually affect HPV in a good way and in a bad way, depending on if you're hypercarbic or hypocarbic. Temperature is important. Warmer temperature actually augments the response. A colder temperature inhibits the response. Cardiac output makes a difference. If you increase cardiac output, it actually makes this response not as robust. pH, for the same reason as CO2, right? So acidosis and alkalosis are going to impact this response as well. So lots of physiologic factors, but also the pharmacologic factors that we see more often.
So for the pH, is it a swing in either direction,
Yep.
or does one? Okay.
Yep.
So just anything away from physiologic pH.
Correct. Yep. All right, so this is the graph that I was mentioning. So this describes the change in resistance in a given pulmonary vasculature tree. So if you were to start off, and they essentially started at 1, so that's the baseline, and then they induced hypoxia here to see what the change in resistance was going to be. And you can see that you first have that initial jump in resistance, and then it plateaus. And it plateaus pretty quickly. It plateaus at about 15 minutes. So the maximal response of that phase 1 of this process is 15 minutes. And it'll stay there until you have prolonged hypoxia. And it's this phase 2 part that we often run into and we often don't think about when we drop our patients off either in the ICU or in the PACU. So the second phase starts at about 45 minutes to an hour, thereabouts, and further increases and augments that HPV, right? It's trying to force blood to go to areas that have good oxygen so that you can oxygenate better. And that continues to go up and up and up for up to hours 2 or 3 hours is kind of what they think the maximal effect is going to be. And then once you start to get oxygen back, it comes back down pretty quickly. But I want you to notice where it comes back down to baseline here is actually not the baseline over here. So this is the part that people say that there are sometimes things that we are doing in the OR, especially in one lung ventilation, where the patient will be hypoxic, relative hypoxic, right? Their HPV will be maxed out because they've been relative hypoxic for hours. And then they go back into the unit and their pulmonary pressures are elevated from baseline. Maybe that doesn't make any difference in some patients, but in some patients it might. So those are the 2 phases that you have for HPV.
What's the mechanism that changes the timing on each of them?
Nobody knows.
Okay.
And it's just a slow come down to baseline, like over the next 24 hours should be back to like normal, presumably, or is it
It's
like
longer than that?
longer
It's
than that?
probably a couple of days. What methods do the CDC recommend to prevent catheter-related bloodstream infections with central venous catheters? We do this stuff a lot, but this question stems from a very small part of these guidelines that we don't ever think about, and I don't think we actually do very often in the ICU. So what about placement? How do we place central venous catheters according to CDC recommendations to prevent these infections?
Full body drape.
Full body drape, right? So max barrier protection, right?
Use ultrasound guidance.
Ultrasound guidance.
Gown, gloves.
So your
mask.
own PPE, right? So hat, mask, sterile gloves, sterile gown.
Washing your hands.
Hand hygiene, good.
Biopatch.
So biopatch. Anything else?
Location.
Location's important, right? So what locations are better?
So subclavian, I think, is the best. Then IJ and femoral being worst.
Yeah, so generally anything above the belly button is considered to be better than anything below. Subclavian is one of those things you have to be careful. If it's a renal patient, that's probably not a site that you want to use. But by and large, that's right. So subclavian would be the cleanest of the options. IJ would be second. What about cleaning solutions? Yeah, so chlorhexidine, chlorprep is what you're going to be using. They've gone away from things that are iodine-based for prep. So we know all of those things, right? What about once the catheter's already in place? So let's presume you've got the patient in ICU. They've had this catheter now for a couple of days. How are you going to prevent it from getting infection?
Sterile dressing changes.
So good. So examining the dressings. If it's a transparent dressing, which we put on most of the time, you just have to look at the skin underneath and look at the site, right? So that makes it nice in terms of examining it. What happens if you have gauze or some other obscure dressing?
You won't see changes under the dressing, so you could have an infection or.
Yeah. So that requires you to actually be active and do dressing changes even if you have clean dressings, and they recommend every 2 days. So let's presume that you have that situation. Doing the dressing change. At the time that you're doing the dressing change, what are you looking for to assess whether there's infection? Erythema is the first thing you're going to look for, right? Let's say that you have erythema. What's the next thing that you would do?
Fluctuates under the skin, like how it feels, and if there's swelling.
Yeah, so actually touching it, right? What happens in terms of the patient response if you were to start touching it and it's infected? Sensitive, right? So that's one of the things. This stems from a question that shows or was looking for the answer of palpation of the site as a way of diagnosing catheter-based infections.
What were the other answers?
They don't give that, unfortunately. So you have to guess a little bit where they're trying to go. But the idea is that that's part of CDC recommendations, that if you see erythema, you palpate. Even if you don't see erythema, you're supposed to palpate the area. Obviously, you do so with it dressed so that you don't contaminate the area. But that's an important part of the whole process. So we're really good with the intra-op and placement part, but then it's the after part. If you have dirty dressings, you want to change those out. You want to keep the area clean and dry.
So if it's erythematous, should you pull it?
That's the recommendation, is that you examine another site if they need central access, or you look to DC it.
So what's really the importance of palpating it if you're going to try to pull it anyway? I mean, still, it's part of the exam, but
That's right.
kind of.
Well, I will tell you that I had a colleague that was not familiar with CDC guidelines on administering medications to patients through their IV. And we had somebody from the State Department witness administration of drugs in a way that is not conforming with CDC protocol and got in trouble. So that's why these CDC recommendations are important to know and to be able to articulate, because oftentimes when you have these regulatory folks come in to talk to you, they'll ask you, so what is the CDC recommendation here? So you have to know these things.
What did the person do with the IV?
I know, that's what I'm
Say it one more time.
What did that person do?
They did not use an alcohol swab to clean the port before attaching the syringe. You see lots of faculty do that all the time.
We have green hubs now.
Yeah, but the argument is there's no studies about whether that actually helps things. So the CDC still recommends that you wipe the.
Swab it anyway.
Aren't they impregnated with alcohol?
They are.
Yeah.
But only once, so if people put them back on.
What about at children's? They just
Yeah, that's not. All right. You are right about that. Let's see. When placing a successful adductor canal nerve block, which muscle is most likely to become weak? Yes. How'd you know that? Good. So vastus medialis. So that is part of which muscle group that we call? Yeah. So it's part of your quad. It's the one on the inside that you can feel that's a little bit more prominent on the medial side. What are the three other muscles of the quadricep?
Vastus intermedius, vastus lateralis, and
What's that?
what did you say?
Nothing.
Nothing.
It's not the right answer. It was the sartorius, is what he said.
Oh, no, that's not it.
What'd you say?
Oh,
You're close. Rectus femoris.
rectus femoris.
Yep. So those are the four, and one of those four can be impacted by this block, which is actually kind of funny because this block initially was advertised as what?
Doesn't cause muscle
It doesn't cause quad weakness, but it actually does. So why is the vastus medialis the one that is most likely to be weak?
Is that just from site of injection?
It's a distal branch, right?
That's correct. So the branch innervating that muscle comes off more distal than the other three quad muscles. And so it's at risk of being affected by this block. I think I put in here, I put in here a pretty neat graph from a study that they did looking at various nerve blocks. So the way that they did this is placebo is red, the adductor canal block is blue, and the femoral nerve block is green. And so what they're testing here is time after the block is on the x-axis, and on the y-axis, this is strength. So strength from baseline. So if it's at 100%, that means they're not weak, and the further down it goes, that means the more weak they become. So this is looking at quadricep strength, and you can see that placebo, they don't get weak. And really with the adductor canal, they don't get terribly weak either, but more so than a placebo, right? So this is actually showing that what we do is that actually causing them weakness. We can't expect them to have full strength. Now, they probably will still be able to support themselves and walk and do these things, which is what the surgeons are expecting and like. But then you see with that femoral nerve block, why the surgeons don't really like that. Why don't they like it? Fall risk. Patients are falling. So that's why the femoral nerve block causes so much more weakness and is not used anymore. How does hypoalbuminemia cause metabolic acidosis or alkalosis? I'm sorry. Say it one more time. Bicarb itself does not bind to albumin, but you're on the right track.
It's like the hydrogen ions themselves. That'd be the.
So you're on the right track too. Has to do with.
Calcium. That was a calcium, and then.
So it's not related to calcium. It's truly a function of albumin. So in terms of acid-base chemistry, is albumin an acid or a base?
Yes.
So it's an acid, and it's a weak acid. So if you are, according to Le Chatelier's principle, right, taking away acid, the response then is to have that overall solution become more basic, right? So that's why you get alkalosis when you have low albumin. So this actually gets pretty complex. We'll talk about strong ions in just a moment, but this picture here is, I think, a way to, in your mind, try to keep things straight. And I tend to break up this image in terms of 3 spots. You have the top and the bottom that you should look at together. You have the middle part that you look at separate. So when you have acidosis, your PCO2 goes up. Alkalosis, your PCO2 goes down. You know that. Down at the bottom with albumin and phosphate, those go in line with your CO2. When those go up, you get acidosis. When they go down, you get alkalosis. So you can pair them together when you're thinking about it. Now, we'll talk at a later time about the strong ion difference, but that's a way to look at all of the ions that you have in solution: sodium, potassium, calcium, all these other ions. And it gives you information about whether you are acidotic or alkalotic. So one of the questions that I'll show at a different time is if you have something that is causing you to have hypernatremia, there's lots of reasons you can get hypernatremic, your strong ion difference is going to go up and you become alkalotic. So it's a way to think through acid-base chemistry with respect to ions. Any questions about that?
Where'd you get this figure from?
I can tell you.
Can you send it to us?
I can send this to you, yes.
Or I guess,
We could take a picture.
yeah, it'll last longer.
Let's go ahead and take a break. And I'll take the CA2s and 3s over next door, and we'll have the CA1 stay here.
I just took a picture of that chart. It was clearly weird.
Oh, that's right. This is the end.
Like stone round.
He said patty cake. That's what he said. He said patty cake.
Yeah.
Yeah.
What we do
Just add
The longer the transport
across the way.
Yeah. So,
The dividers go up.
if you just go to the ALP
How are you? I'm good. You?
Add your own people to the list. You slob.
so that was the reason why I got into it.
Didn't you do that? Because I have to look at what block you did, and then I have to look up how much you put in.
Wait a minute.
And then,
Didn't
did you do
somebody
a catheter? Is
Didn't
this
somebody
thing
go
that's
through like
12 years
simulations
ago.
today. You had like all this free time.
Yeah,
all the
on
energy.
I'm actually not even block resident, so send it to Paul if you'd like.
You're on what we call team consequences.
I'm rounding. I'm also holding the pager, which I'm not supposed to do for this time.
A lot of people complain about that, but not you.
That's right.
All single shot
All single shot. Will you just text Paul? That's like his actual job. Yeah.
Is he still over there?
Yeah, he's like the actual block resident. Yeah.
She's awesome.
And if he gives you any gaps, then text me.
But he admits that it's like it's a different vibe.
Having a baby.
He sounds like he lives in the
And then both when he's what's your name? Kenny's going to like Puerto Rico. So I know she was not. I well, yeah, this is supposed to be protected. Yeah. Well, they were gone though, and I realized that was what's happening.
Like, is there anything there's supposed to be going on?
So there is.
Beth actually told me her today, like there's something on the ABA.
There is. There's a contact.
Yeah, that's what you want. Okay, sure.
Hey, are you guys gonna move up here?
No, I'm good. I'm good.
I'm just gonna go get a cookie.
It's funny, on a map. I'm always on a map now, so whenever it comes to what's that? I'm always on a map now, so whenever I have something to do on a PC, I can't ever figure it out. It's always on the map.
Well, that too, I wish.
Why is it not popping up? So what's the deal? You take the third years out? Second.
By the end of
Like a pile of this kind of nonsense on my flash screen.
I know. I was
I'm like, what's the point? I don't know. Oh, you know, I do.
They want you to. It's probably.
I got myself a very shiny notebook, but I'm pushing
And then too, like, I mean, we'll just get looked back over.
Wait, why do we hold the picture for so long?
Call to you.
Oh, because they won't.
So
They literally refuse.
Okay.
My boys look for now. So I actually prefer me over my for but they don't. Most people would say that no. Probably the wrestling helps.
People that have medicine and mid-up. And we'll take out the heart.
Replace it with a new one.
Yeah.
They just turned the left. They did. And we've been actually talking about Anesthesia.
What? No, admit her. And the intern was like, I don't think that I can do that. He was like, it is the middle of the year. You can call medicine and have them and have. But no, she's not going. This is like 7 p.m. too. She's been like sitting around all day long. It's like seriously.
Well,
You're there. And what's the time frame? What's this supposed to be?
no later than 5. So we can finish early.
Short as you can. A lot of notes.
Fly through.
Too many notes?
So I can get back to reading.
Any notes is too many notes, but.
Anyway, okay.
I mean, like, you hardly ever get paged, but there are times where you get like 4 pages during this time because it's when the interns are realizing that, oh no, they need a consult. Never have had sympathy for that because I was up with them at 10 a.m.
Oh yeah, I got it done. That was the first thing I did.
Because that's what you're supposed to do. That's like the respectful thing to do. You don't wait till 6 and be like, hey, this person that I took off their Lyrica is now having horrible, horrible pain. What can I do?
Okay.
I don't know.
That's okay. This is who from that team? Sorry.
On my first day, I literally had this poor intern call me. I was like, yeah, no, there's...
When I'm done, do I need to do anything? Hey, Tony,
person.
when I'm done, just turn this off. Power off.
So we can't give it
Okay.
to her.
Or you can drive yourself something.
So I don't really know what to do, but he was like really anxious. I got like counseling and anxiety. I was just like, this is not what APS is consulted for. But sure, I will help you. But then I was like, yeah, that's not what I do. You want to start someone on ketamine? Sure, I'll do that. Yeah, I got real salty for that. Hendrix was like, you do realize that you were them 8 months ago. And I was like, yeah, but I'm not anymore.
How's everybody doing?
Good, how are you?
Good.
Did they make you drive all the way out here?
It sucks. This guy's terrible.
Do they not schedule it on a day that you have like meetings over here or something?
I don't. I come once a year, maybe twice.
Because that's what Beth does. She does.
Yeah,
like,
now she does more of the residency selection stuff. I don't. Beth and Dave do that. Yeah, I mean we just try and schedule an earlier day, but it's just it takes. You forget how long it takes in the early afternoon. You could give it 10 more time, and I guess I didn't really.
What's that intersection of like
I
6?
park pretty far away.
It takes like 20 minutes to get past.
Oh, nurses aren't allowed to consult you.
I know. I heard that.
Say Dr. Have someone else call back 10 minutes later.
Yeah. Say what? Yeah, I'll get it.
Yeah, now that's.
Well, it was like, he got this thing.
What are you
they
on?
put
What's
beads
everybody
in
on?
his belly. I was like, what? Who is this from the team? I'm on APS.
Is this everybody, bro?
Yeah. There's a door right there that's closed.
Okay. So I have endocrine. They don't give you any kind of particular reading for this, right? All right. So endocrine, become an endocrinologist, 3 years internal medicine, 2 to 3 years for fellowship, and then 2 years, and then most people they make do a fellowship afterwards on top of the other specialization. So it's basically 6 years residency, and we're supposed to cover all that in like 30 minutes. So I kind of focus this on the things that I kind of remember seeing in service or on tests. And unfortunately, this was on there as well. You think it's a step 1 question, but it did show up for me on, I can't remember, is it in service or anesthesia boards or which in particular exam it was. But they still kind of expect you to spit this back out. So what do we think here?
D.
Yeah, I actually don't even feel like reading the answers, so we'll just move on. So men, like I don't know if it was A, B, or C, but men 1, it's the P's, pancreas, pituitary, parathyroid, autosomal dominant, and men 2 is, there's a better slide here, has thyroid and several subtypes. So men 1, I don't know is this show up in ITs yet? I did have to regurgitate this once or twice during anesthesia, and I was pretty surprised by that. But with men 1, 3 Ps, parathyroid, pancreas, and pituitary, they get lipomas, angiofibromas. Men 2, thyroid, TAP, thyroid, adrenal, and parathyroid. Men 2B, the TAN, or thyroid, adrenal, and the neuromas. And then 2A and 2B have familial thyroid cancer as well. So you might see those with the thyroid surgeries. And this lecture might seem like it's a bit of a hodgepodge, but it's just a pretty broad topic, and I'm just trying to kind of hit on some particular areas that you might have to see again. So the hypothalamus. Does this get broadcasted? Are people listening?
I think they can see what your slides are, but they can't hear you.
We can sort of hear you at Denver Health.
Yeah, you can hear Denver Health.
Anyone at Denver Health?
We always
hears text me.
They all went home.
What's that? It's only 2 of them, and honestly, they probably should. It's so hard to get something out of this from a distance. It's hard to get something out of it when you're sitting right there, but it's even harder from a distance. So we'll go over the hypothalamus, location, function, neuropeptides. Hypothalamus here. So we have the brain, the corpus callosum. Below the thalamus is our hypothalamus to the pituitary gland and the pineal gland. This, I think, was kind of interesting. So pineal gland, named after a pine cone, produces melatonin, serotonin-derived hormone, which modulates sleep pattern in both circadian and seasonal cycles. Anyone taking melatonin? No? All right. So what dose do you take? What?
The lowest doses have actually been shown to be the most effective.
Yeah, and so how do they sell it? It's hard to find ones. It's mostly 3, 5s, or 10s.
Yeah.
If you look at sleep hygiene recommendations, sleep hygiene's actions that improve and maintain good sleep. So you're supposed to sleep until you feel rested. Don't come to work until you're rested. Maintain a regular sleep schedule. You want regular wake times. Don't force sleep. No caffeinated beverages after lunch. No alcohol near bedtime. No smoking or nicotine. Reduce bedroom environment to decrease stimuli. No TV or radio. Don't look at your phone before bedtime. Resolve all your concerns or worries. This is up to date. Exercise for at least 20 minutes, but it has to be 4 or 5 hours prior to sleep, and avoid any daytime naps. This is what is recommended for good sleep hygiene. Personally, I don't smoke, and I rarely take daytime naps. Otherwise, I probably do everything else wrong. So melatonin is a hormone secreted from the pineal gland. It's recommended for treatment for insomnia in most patients for sleep disturbances, delayed sleep-wake phase syndromes. It's less safe and appears to be safe when used for short term. This is the dosing from up to date. Basically, it's recommending 100 to 300 mics. When it's sold, it's hard to find it less than 3. It's 3, 5, or 10. I was talking to Melissa, one of the CRNAs there. I don't know if you remember her. She's like, oh yeah, I do that post call. I normally take about 20 because of the gummy worms.
Apparently, you can't overdose on it.
Yeah.
It doesn't really matter.
And it seems like most people I talk to or at the lunchroom there, most people are taking around 10 who take it. I've taken the smaller doses, and I think it actually helps. And I think if you want to use it post call, when you actually want to go to sleep, or the days I'll use it is the days on post call I'm up all day and I've been drinking like caffeine all day long, and then it's just all of a sudden you want to go to bed at 10 o'clock and you're just wide awake. I think it's been helpful there. It helps you fall asleep. It doesn't necessarily help you stay asleep. But I think it's actually pretty useful. Have you used it much?
I used to when I was on night float.
And then you make yourself sleep in the morning? Mm-hmm. Yeah, so I'm actually, my personal call schedule, I'm going to do like 3 calls in a row there just to see how, and I'm just planning, I'm going to come home, I'm going to take melatonin and try and sleep during the day and see if I can just adjust the schedule. And if you have to adjust, it's probably worth playing with a little bit, potentially.
Yeah.
Any thoughts?
Just from like anecdotal experience, the lower doses do work much better. When I was an intern, I would literally switch every single person to the single or the 1 milligram, and they would have better sleep overall.
What, as opposed to the higher milligrams at night? Yeah, Murray's using it like on all his like MAC cases, like 6 milligrams, just kind of.
Awesome. I think the Epic pre-populated doses are 6
like 3,
and 12.
6 and 12.
Yeah, no, it's huge. And if you look at the up to date, it's just it's more that I wanted to kind of bring that up. It's kind of endocrine related, and it's kind of interesting.
The reason why is that I think it's like 100 to 300 micrograms is the amount that we produce on our own. So it just
you're replacing the physiologic
dosing.
Is it fully bioavailable?
Yeah, this is like, if you read that.
Oh, that's why the recommended dosing is not 100 to 300.
But yeah, there it's basically, that's your physiologic dose, and you try to replace that. So I just break the 1 in half.
Does it help with Murray's Max? Does he like it?
With what? He says he does. He's still kind of experimenting. He gives him like 6, and she's like, try and keep him asleep for a little bit. All right, hypothalamus, basic survival functions, intravascular volume regulation, reproduction, energy, metabolism, growth, circadian rhythms, hunger, vigilance, arousal, anger, and aggression. So we got our hypothalamus going down to anterior and posterior pituitary. Posterior pituitary, just the ADH and the oxytocin. And the anterior pituitary, and this is our pituitary portal system. You'll see anterior pituitaries, FSH, LH, growth hormone, prolactin, ACTH, and TSH. All right. So, case 65-year-old man, history of hypertension, morbid obesity, gynecomastia, secondary to prolactin secreting tumor, undergoes transsyphoidal hypophysectomy. The operative course is unremarkable with an estimated blood loss of 50. The patient was extubated in the operating room and transferred to the ICU for post-op care. Overnight, he developed an elevated urine output with urine volumes exceeding 300 mLs. Urine-specific gravity was 1. Plasma and urine osmoles were 120 and 290 respectively. What do we think's going on?
FADH from damage to the pituitary.
SIADH. So you calculate your serum osmolality. This is a formula that I think you get these on most. I think they give you these. So I don't think you actually have to commit this to memory, but it should look familiar, like 2 times the sodium. Glucose over 18, B1 over 2.8, and then alcohol by 3.7. I asked as a medical student what a normal alcohol level was. During my ER rotation, they weren't impressed. But anyway, so prolactin secreting tumor undergoing transphysoidal secondary to prolactin secreting tumor, and this is the most common postoperative present diabetes insipidus. So you have the secretion of vasopressin as the portal circulation of the posterior pituitary is blocked, and that's presumably by swelling of the posterior pituitary initiated by surgical manipulation of the anterior pituitary. So the production of vasopressin in the hypothalamic neurons remains intact. So you have a high normal plasma sodium concentration due to water loss, and it would, actually I didn't have the whole question there, but would point towards DI. So if you have a ton of urine immediately after a surgery, it's diabetes insipidus. And so the treatment is you got to replace water. I've only seen this once or twice, but it's all the time on these boards. And they were doing, almost like 500 cc's of just urine, just nonstop. And let's see. I get there. So, you have the hypothalamus, you have swelling there, and it's just kind of interrupts the posterior pituitary from being able to get the signals or secrete that. And so you see diabetes insipidus, and that's something you'll have to know for clinically and for tests in the future. The 3 things you'll frequently see is cerebral salt wasting, SIADH, and diabetes insipidus. So with diabetes insipidus, for the one that question was about, you're making a ton of urine, so you're going to be hypovolemic. You're making a ton of urine, your serum sodium will be high. Your urine sodium is decreased, and your urine output's increased, and that's free water loss due to decreased ADH or vasopressin. And then the other one that's harder to kind of distinguish is, so that's a hypernatremic state. The hyponatremic states are the cerebral salt wasting and SIADH. SIADH, how do you really distinguish them? Supposedly the volume status. So with cerebral salt wasting, they're hypovolemic, where they're more typically euvolemic with SIADH, but your serum sodium concentrations are going to be low with both of those. Urine sodium will be increased with both of those. Urine output is normal with SIADH, or is increased with cerebral salt wasting. And the mechanisms are with cerebral salt wasting, you have excess secretion of sodium in water, or SIADH, you have water retention due to elevated vasopressin. When do you see cerebral salt wasting? Never did get a text, did I? So cerebral salt wasting, another potential cause of hyponatremia in those with CNS disease, particularly in patients with subarachnoid hemorrhages. So if you see subarachnoid hemorrhage and hyponatremia, think of cerebral salt wasting. And it's inappropriate sodium wasting in the urine is kind of how it got named. If you look this up, read about it, some people debate whether or not there's really much of a difference between cerebral salt wasting and SIADH. Diabetes insipidus, associated with deficient secretion of ADH, and it is most often idiopathic or can be produced by trauma, pituitary surgery, hypoxia, ischemic encephalopathy. So what does it sella turcica mean? This is kind of funny.
That's what the pituitary sits in.
Yes.
Isn't it the saddle of the Turk?
Turkish saddle. Yeah. So if you were to actually look that up on the Urban Dictionary, it'll actually, the second part of the definition says, much in the same way the sella turcica cradles the neuro and adenohypothesis of the pituitary gland.
What's the first part?
I can't read that to you.
They're not listening.
But sella turcica, someone told me that it's in there. I was like, are you kidding me? But yeah, it's there. So the pituitary. We'll talk about location, function, hormones. You kind of touched upon that a little bit. So posterior pituitary is oxytocin. So hormones are thyroid stimulating hormones, ACTH, vasopressin, growth hormone, FSH, LH, oxytocin, and prolactin. All right, so the hypothalamus, we kind of covered this. I thought this was originally a little bit longer lecture, so I'm going to kind of go through a couple of these a little faster. So anterior pituitary does all the following except what? A, yeah. So anterior pituitary, growth hormone, ACTH, TSH, FSH, LH, prolactin. Posterior pituitary is only two, oxytocin and vasopressin. So anterior pituitary, we'll just briefly go over a couple things and if they're potentially related to anesthesia. So growth hormone affects anabolic, increases rate of protein synthesis, and ketogenic increases mobilization of free fatty acids and decreases rate of glucose utilization. So giganticism, excess secretion of growth hormone before epiphyseal closure, whereas acromegaly is excess growth hormone after epiphyseal closure, resulting in increased soft tissue mass in nose, mandible, hands, feet, and causes coarse facial features. Why do you care about this in anesthesia? With acromegaly, they can be prone to glottic stenosis from excess glottic tissue growth. Can manifest as hoarseness, difficult intubation. You can cardiomegaly and hepatomegaly sometimes seen, and some macroglossia, which can make it for difficult intubation. So, the difference between giganticism and acromegaly is when the growth hormone happens and whether or not the epiphyseal closure has happened.
Can you give me the name again?
All right, prolactin, stimulated by development, stimulates growth and development of breast, preparing pregnant women for breastfeeding, inhibits ovarian function, decreases fertility in lactating women. Secretion spontaneous, inhibited by dopamine from the hypothalamus, negatively regulated. Has a pulsatile nature prolactin due to the pulsatile hypothalamic inhibition, and secretion. Stimulant for secretion include pregnancy, active breastfeeding, stress, and physiologic sleep, and also metoclopramide or Reglan, cimetidine, opioids, and alpha-methyl-dopa. And it is inhibited by prolactin itself. Another thing from the anterior pituitary is ACTH, stimulates the secretion of glucocorticoids from the adrenal cortex, mainly cortisol. Secretion is stimulated by the corticotropin-releasing hormone, decrease in cortisol levels, stress, the sleep-wake transition, hypoglycemia, trauma, alpha-adrenergic agonists, and beta-adrenergic antagonists. Secretion is inhibited by cortisol. It has a diurnal variation, highest in the morning, lowest in the evening, and the adrenal cortex undergoes atrophy in the absence of ACTH. I think you guys are familiar with thyroid stimulating hormone, vasopressin. We kind of talked about that already. So normal cortisol production per day is around Sorry?
Is it 10 to 15?
I think I actually have B here. That's actually when I was looking over this, when I had to guess, that's kind of what I was guessing too. But I forgot. Yeah, but it was 20 to 30, so 15 to 20 to 30. It's one in there.
The AM one is like
but it just
greater than 20.
What's that?
If like the AM one is greater than 20 with like ACTH test, that's when you know that they're depleted.
Or if it's less than 10 is when you actually do the whole stim test.
Yeah.
And if it's not, if it's just high, then it's not the case. It's hard to get positive. I've had, I would say, less than 5 positive stim tests in my career. I don't know if you've had any.
I think they like switched up the.
It's hard to actually get a negative
parameters
test
recently. I don't know. Medicine people liked it.
Yeah, we'll go over the different ones in a second. But basically, yeah, I think you do have to kind of spit out kidneys, neuroendocrine glands, inner and outer adrenal cortex, and then the epidural, the embryologic origin, probably not. But for the cortex, membrane, GFR, glomerulosa, fasciculata, and reticularis, and then the medulla, and then aldosterone, cortisol, and the cortex, and the catecholamines in the medulla. So mineralocorticoids, aldosterone, GFR, fasciculata is cortisone and cortisol, and reticularis are androgens. Cortisol controls carbohydrate and protein metabolism, fatty acid mobilization, electrolyte and water balance, and anti-inflammatory response. Facilitates catecholamine synthesis and action and regulates the beta-adrenergic synthesis coupling and responsiveness. Also contributes to normal vascular permeability, vascular tone, and cardiac contractility. I just want to give me 1 second here. So we're not here all day. I just want to see what I actually feel like covering and what I want to skip. So, estimated daily cortisol production 5 to 10, roughly 15 to 25 of hydrocortisone, or 5 to 7 per day is kind of your normal. All of ours are probably a little higher from stress, but if we made different life decisions, we might be around that level. But during major surgery, it can jump up. And the only thing to think about is the doses we give are kind of on the same scale as the melatonin, where we're kind of giving super physiologic doses to patients. And this slide kind of gives you relative equivalent dosing, anti-inflammatory, and the mineralocorticoids. So why do we give dexamethasone most frequently? It doesn't have a mineralocorticoid effect. It is kind of the most anti-inflammatory. So when we cause inflammation in the airway or anything like that, if it takes a couple times to intubate, or if they're having ENT surgery, it has by far the highest kind of anti-inflammatory potency compared to glucocorticoids, though. For adrenal insufficiency, it's not given in those cases because there's no mineralocorticoid activity. It kind of makes you wonder why they don't give it for asthma, though, that's something that's always kind of bothered me, and I never could find a good answer. So clinical manifestations of mineralocorticoid excess include. Let's see. Yeah, this was actually just on medicine boards. I just had to retake those or something along those lines. So hypersecretion of aldosterone, increased sodium resorption in the distal renal tubule, and in exchange for potassium and hydrogen ions. Actually, before I forget, since we're talking about distal tubule, when I took anesthesia boards, there's a picture of the kidney, and there was like, furosemide, mannitol, and 2 or 3 other diuretics, and you had to say where it works, and it just showed you pictures with arrows there. And then talking to a buddy of mine who is, 2 years behind me, and I was like, don't bother studying that. They're not going to ask that again. I couldn't believe that was on mine. It was on his as well. So that is something that's just kind of come up a couple times. I've never had to take that on medicine boards or had to do anything like that. But for the boards I had to take for anesthesia, and I know it's been on there twice, a picture of the kidney with little arrows and where all the diuretics work. Anyways, so hypersecretion of aldosterone, increased sodium resorption in the distal tubule in exchange for potassium and hydrogen, which would cause fluid retention, hypertension, metabolic alkalosis, hypokalemia, and muscle weakness. Or this is like Conn syndrome, and this is JFK, right? So aldosterone, salt wasting. I gotta keep going. I'm starting to lose some of your falling asleep here. That's all right. All right. This is something that's also probably pretty testable, and it could also show up as well. So what happens if you have dehydration, sodium deficiency, or hemorrhage, decreased blood volume, decreased blood pressure, works on the justicular cells of the kidney, increases renin. Renin causes release of angiotensinogen, which goes to increases angiotensin 1 to the lungs with angiotensin converting enzyme to increase angiotensin 2. If we follow that around, we get to the adrenal cortex, increase aldosterone, and kidneys, increase sodium and water resorption, increase secretion of potassium and hydrogen into the urine, increase blood volume, and blood pressure to normal. There is a new drug out there. I think it's just a new vasopressor that you guys have used. Like, I'm on a P&T committee, and I think you guys used it once, or the University of Colorado used it 3 times or something, and they're trying to get it approved there, and it's ridiculously, supposedly pretty expensive, but it's just actually angiotensinogen that they're giving, which is pretty unique. You'll probably see that in a couple of years. I don't think it's really was approved by P&T at either institution yet, but that's a vasopressor to keep your eyes on in the future.
Didn't it show no benefit over norepinephrine still though?
Yeah, that's why, and it was pretty expensive. So, but then people who are the critical care people who were saying is. It was studied in about 20 people. It wasn't, the big, but it didn't. But the argument was if we have, young people who are septic, and if that's not working, it could be something additional to add to the armamentarium. But yeah, it didn't have robust data. But yeah, I don't know. Maybe it'll come down the line. Maybe it won't. I guess it made it through, but it's probably at its current price. It wasn't approved at Denver Health, and I don't know. The pharmacist who spoke to pharmacists here says it's kind of got strong-armed into using it a couple times here. Like, they'll just approach a pharmacist. The patient will die if you don't approve it, and I'm just like, that's kind of how it works. Yeah. All right, good old pancreas. 5 hormones secreted: insulin, glucagon, somatostatin, pancreatic polypeptide, and amylin. We're going to try and wrap this up in about 10 minutes, so I might just kind of go through there. Insulin is something you guys are all pretty familiar with that, right? Anything else I need on that's of incredible importance on this slide? I kind of didn't spend a lot of time on insulin or the pancreas or diabetes because I kind of figure you're seeing that. And these are the other things like the men and all this other little bit more esoteric stuff you kind of forget about. Thyroid, parathyroid hormones. It's parathyroid hormone. It's secreted by chief cells of the parathyroid, and it's polypeptide containing 84 amino acids. It acts to increase the concentration of calcium in the blood. And calcitonin, it's hormone produced by the follicular C cells of the thyroid, acts to decrease calcium concentration. Parathyroid, it acts to increase the concentrations of the by acting on parathyroid hormone 1 receptor and parathyroid hormone 2 receptors. So if we look at our calcium regulation cartoon here, parathyroid, calcium resorption, vitamin D hydroxylation, works on kidneys, kind of comes up in the blood. Most frequent time you see hypocalcemia is with massive transfusions, liver transplants, and traumas for the most part, where citrate's binding to calcium. And you're either giving calcium chloride or calcium gluconate. All right. So maintain calcium homeostasis primarily dependent on parathyroid, vitamin D, and calcitonin. Parathyroid increases plasma calcium by 3 mechanisms: augmenting bone resorption of calcium, promoting renal reabsorption indirectly through renal activation of vitamin D. So hypercalcemia, so normal calcium is about 8.5 to 10.5. Cause of the hypercalcemia, hyperparathyroid and malignancy, accelerated bone resorption, excessive GI resorption, impairment of calcium excretion and bone mineralization, and Paget's disease, prolonged immobility and high levels of vitamin D. You typically don't see this until when serum calcium is greater than 14. Signs and symptoms: weakness, fatigue, coma, pancreatitis, polyuria, polydipsia, nephrolithiasis, short QT, bradycardia, first degree AV block. Treatment for this: parathyroidectomy. Treatment of underlying malignancy. Specific therapies used to reduce calcium include IV hydration with normal saline, loop diuretics, bisphosphonates, calcitonin, and glucocorticoids. Pretty rare. I can't really think off the back of my head how many times I've really had someone present with hypercalcemia. I think this was the bones, and groans that.
I had it last year.
What's that?
I had it last year. It was like all of those things.
The bones, psychic overtone.
You just slammed them with fluid.
You slam them with fluid and it gets better, right? And you sometimes give Lasix, but that's kind of controversial if you actually need to do that. If their heart's good enough, you just slam them with fluids and it pretty much gets better on their own. What was it?
Common in onc.
And then we started calcitonin.
Yeah.
Bisphosphonates.
Calcemia, hypoparathyroid deficiency of vitamin D, acute or chronic renal failure, resistance to parathyroid action, resistance to vitamin D, acute calcium deposition, rhabdo, citrated blood product transfusion, skeletal mineralization, pancreatitis, and hyperphosphatemia. Signs and symptoms: neuromuscular irritability, diffuse muscle cramps, positive Chef-Stock sign, that is spasm by tapping on the facial nerve, or Trousseau sign, carpal pedal spasm while inflating the blood pressure may be present. And then the other thing is thyroid storm. How do you treat that? Potentially change. Let's go over that. So medical emergency if untreated. Supportive treatment includes killing, hydration, beta blockers to control heart rate, propranolol. If you're given a beta blocker, has the additional benefit of inhibiting peripheral conversion of T4 to T3. PTU and methimazole inhibit the synthesis of T4 by blocking the organification of tyrosine residues. Iodine blocks the release of preformed thyroid hormones, but should only be given after loading doses of anti-thyroid medication to prevent the utilization of iodine in the synthesis of new thyroid hormones. Administration of cortisol is also recommended to prevent complications from coexisting adrenal insufficiency. Questions about anything? You guys all look tired. And it's kind of dry. I don't know if you have, is there anything on that you kind of wish I would have covered or?
What's the most common out of these? It's like the most common thing you'll see intra-op or
what is
acutely peri-op.
Probably hypocalcemia. Hypotension with hypocalcemia is the only thing I think you really necessarily see that much. And then a FEO is kind of a different ball of wax, kind of entirely. I had one with Aaron. You were there for that. Actually, we have a couple minutes. Let's just talk briefly about if someone has a diagnosed FEO. So this was like a 60-some-year-old lady. EF was about 15 to 20%. She was on 3 or 4 blood pressure medicines, diabetic, and was found to have a FEO. How would you get her ready for surgery? By textbook.
I think you need to get them like irreversibly alpha blocked.
You alpha blocker to what point?
That's a good question. Titrate to like normal blood pressure or something, or
you would titrate that, or say titrate so they're almost orthostatically hypotensive, and you could add a beta blocker at that point. Benzamine or would be a traditional one. Frequently now, what we've done recently is kind of whatever is available as an alpha blocker you could give as well. This patient was already on a beta blocker, was taking that, and she was taking some ARB as well, and with both of those, her blood pressure wasn't that high. We didn't actually have her on, I don't think, did we get her on? Yeah, I think we did get her on like Prazosin ahead of time, or Tarazin, one of those. Took that, comes into surgery. If you bring a patient into surgery, what are you supposed to do? At what point would you cancel surgery, or would you do it? If they come in, they're like 150 over, if they're like 180 over 100, would you do it? Is that
180 over 100?
Yeah.
I wouldn't be excited about it, but I think I'd say
I had one where it was like 180s over 120s, and the surgeon wanted to cancel it because she wasn't taking her medicines. More recent one, there's something called the Rosen criteria that has to do with, you're supposed to put the patient in a completely stress-free environment, make sure they're normotensive, put them on a monitor, make sure that they don't have any PVCs, to make sure their heart rate is, controlled as well prior to proceeding. This is about 20, 30 years ago, probably, where this was, I think, a guy at University of Pennsylvania came up with this. Subsequent to that, I think our drugs have gotten a lot safer, and most people will not follow that now. So they'll try to alpha and beta block them. If they become too orthostatically hypotensive, you could actually give them fluids at that point if they need that. What was kind of unique about the case I did with Erin was the patient had like an EF at like 15 to 20%. So if her blood pressure was good, you're just kind of like, let's just not mess with her meds. I mean, how much do you want to, drop someone's blood pressure like that as an outpatient? So we kind of thought we would just tell her to take her meds. She came in. She was relatively normotensive. What would you get set up if you're doing that case?
Pre-induction A-line.
A-line.
Would you do a pre-induction A-line?
Probably with that patient with the low EF. But
okay.
Otherwise, I think
central line.
Yeah.
Central line.
Because you're probably going to have to end up using pressors.
What's that?
You're probably going to end up using multiple pressors.
Okay.
For the FEO.
And what else? So central line, A-line, you would do it pre-induction.
that patient. I don't know that you necessarily need to do it for everybody, though, I guess.
I think we actually did. I can't remember. Yeah. But it's someone like that. Those are times we did that, use lidocaine, and those are times I think just use the ultrasound. Go make it one stick, get in and out. It's supposed to be a stress-free environment. You don't want to piss them off, jabbing around all over.
Dim the lights.
Get rid of all the catecholamines.
Yeah. Maybe
So I kind of big proponent there. Numb it up, use the ultrasound, stick it once, get in, get out, done. We went to sleep relatively without too much incident. You want to have someone with experience. So if you have a med student with you, that's probably not the airway you let them touch. Or
Did you all do an
the paramedic
LTA
student
and stuff?
comes in. What's that?
Did you do an LTA or?
Yeah. I think the other thing with when we induced this patient, we used, and we also put an epidural in her as well because they thought it was going to be a huge whack open. And we spent forever getting this epidural in. It was a late start, nothing, and they ended up doing the case laparoscopically, and we pulled it by the end. So no, it was good, but we should stab forever. And I think we finally got it, and then we did a central line and drug it. I think so. You need start the case. You need to have a couple drugs to bring the blood pressure down. So frequently. I think we just had nicardipine. So this patient has like a propofol nicardipine, or I think it was actually just nicardipine and remifentanil infusions to start with. I'm also a big fan of bolusing remifentanil for stimulating parts. Like if they're getting ready to manipulate the tumor, bolus remifentanil because, they let go of the tumor and you stop secreting all those hormones, your pressure can potentially drop. So I think remifentanil is a great drug in this situation. Normally don't use a whole lot of it, but I think this is a time it's particularly indicated. Then as soon as they cut off blood supply to the tumor, you need to have the ability to acutely raise the blood pressure as well. So we went from, remifentanil nicardipine within 2 minutes to, I think, vasopressin and norepinephrine immediately afterwards. And by the end of the case, she kind of settled out. Within 2 to 3 hours, she was off all her pressors. 2 to 3 days, she was actually even off her insulin. It was actually normotensive. She went from about 3 or 4 blood pressure meds to kind of going home on nothing. And had a sister who supposedly had her sister actually had a heart transplant here for cardiomyopathy. So you wonder if there could have potentially been a missed familial component to this VO. Yeah, that's right. There was a familial cardiomyopathy in her sister. What's that?
2A or 2B.
that?
Maybe MEN.
Yeah,
2A,
no,
2B.
definitely.
Well, she had a VO when it comes
So
to
with the VOs, alpha beta block, get it under control,
Because those are the
have the ability, probably pre-induction A-line with these, especially if you're ever on an oral boards. And it's got to be, as calm as possible, relaxed environment. I would give sedation if necessary to make sure they're calm. I don't want to do anything that's going to cause them to release of catecholamines, all that good stuff. You got to try and make the laryngoscopy as smooth as possible. If it looks difficult at all, just get a glide scope so you're not yanking away there. And then you have to have stuff to bring up and bring down pressure, because you're probably going to have to do both if it's a real VO, and so central access as well. Done before 5. Any other questions? Is that kind of? I've never heard any of your other lectures. Is this kind of what you kind of expect? Is this good, bad, just honest? What's that?
It's a mixed bag.
Is this? What do I do to make this better for kids next time?
Yeah, just talk about like anesthetic manifestations or ramifications for all of them.
Yeah. No, yeah. Oh, there's probably a little. I guess I was surprised when that these like what I would have perceived to be step 1 things were showing up, and that's why I did kind of go a little bit. Maybe I went a little too far on just that basic kind of stuff, and you guys, all your eyelids are just drooping. All right, yeah, I could do that. Anything else? No. All right.
Do you mind actually emailing that to us?
Yeah. I don't think I have email here. Yeah, I'll get that to you guys. Is it just you four?